start with our profession in general began in 1860. That's the year Florence Nightingale opened the first school of nursing. So that was 162 years ago. 1979, only just 43 years ago, AAACN held its first meeting as an organization. At the time, there were 223 members. Today, we recognize over 4,000 members. 1997, only just 25 years ago, CalNOC was established. I think this is the most pivotal year thus far in our nursing history. CalNOC stands for the Collaborative Alliance of Nursing Outcomes. It is the first organization developed by nurses, for nurses, to do this nurse-sensitive indicator work, to help us put standards around our practice, to help us embed best practices, to help us with data and metrics that speak to the value that we bring as nurses. CalNOC is actually responsible for what we now know and recognize as inpatient metrics, line infections and pressure ulcers. And so 3 years ago, Press Ganey purchased CalNOC, 2019. And I am here to share that there is collaboration with Press Ganey, with AAACN, and specifically with our nurse-sensitive indicator team. It seems that they're very interested in picking up where CalNOC left off, so we could not be more excited. Stay tuned, we're paving a different path forward. I wanted to just briefly speak to some challenges as it relates to our patients today, because they're not patients like they were years ago. The bulk of care is provided in ambulatory today, and it wasn't years ago. And some challenges we have as it relates to our patients specifically is our ability to affect change with our limited time that we see them in the clinic. We often have to share it with other providers. And then the space, our clinic rooms are really hot commodities, get them in, get them out. So our ability as nurses to actually make a difference, given those constraints, is really compromised. And then our patients themselves, they're just simply sicker than they've ever been. They're discharged sooner, they're more medically complex. Their own ability to take in information and learn and engage in their care is also doubly compromised. And then the care that we provide has always been hard to capture. It's qualitative. We know we give good care in ambulatory. We hear our patients tell us all the time, "Thank you so much for teaching me about my diabetes. No one has ever explained it to me that way before. I get it, I got it, I'm good." And then we go on to see their diabetes get better. There were no medicine changes, there were no medical interventions, so we can pretty much be sure we made a difference, but we don't capture it yet. And then nursing triage. If you're a nurse in ambulatory, you're doing some triage, if not a little bit, the whole day. And so what value does that bring? Why does that matter? Let's see. We are symptom managing over the phone. We are reconciling medications over the phone, making sure the patient gets the right medicine over the phone. We're providing education over the phone. We're keeping them out of the emergency room when they don't need to go there. We're bringing them into the clinic when they need to come into the clinic. And all of that is so valuable. It's valuable, first of all, to the patient. They don't want to come in every time they have a symptom or a concern or a question. And it's so valuable to our teams. They do not have time to see patients that are currently in their schedule. And it's incredibly valuable to our organizations. It's a really efficient way and cost-effective way to provide care, but we are not currently capturing it. We don't currently have ambulatory metrics around telephone triage, but our nurse-sensitive indicator team has heard you loud and clear. We have heard that our AAACN members, that's the #1 standard you want us to help put metrics around. So we hear you, we got you. Stay tuned. I have a whole list of nursing challenges. I can't speak to all of them. I chose one, which is role dilution, and I think that history has brought us to where we are today. We are struggling with all of us coming to work and all doing the same thing, just all meeting the basic needs of the clinic. If Sally calls in, and Sally's an LNA, Nancy, who's an RN with her ADN, BSN, MSN, must not and should not be asked to fill in for an LNA. That's not our skill set. That's not our job description. That's not our education. And we need to stop being used as fillers. And we need to start using our voice to say, this is what I bring to practice. these are the metrics and the standards and the outcomes, and this is why I'm a nurse. And I think we haven't used our voice well historically, and we need to start. And death by 10,000 initiatives is never going to change. You know, it's always going to be something that comes along that's more important, that demands our attention. COVID wrecked us all, right? But you know what? Our nurse-sensitive indicator team pushes this work forward, and throughout COVID, despite everything that we were struggling with, we push this work forward because we see that it is as important as providing patient care. And I think that's where all nurses need to get to. This work is essential. And my last slide is simply a call to action for us, that for 20 years in a row, we have been voted the most trusted profession out of all the professions. That is quite an honor. And I think we need to continue to earn that honor. Yep, our patients need us more now than they've ever needed us to advocate for them. They need us to be top of our game. They want us to bring them the best practice. They want us to embed the best practice and provide care to them like we would our own families. Just like on the inpatient side of the world, we are the direct link between safety and quality in ambulatory, and they need us, top of our game. And when I say responsibility to the patient, I specifically mean that there is a nursing social contract. When you signed on to be a nurse, you signed on to be engaged in your practice, to always be bringing your best forward, to always be serving society the best that you can. And my last piece is that we need to take care of each other. I don't care if you're an LNA or a CNO, we all have a role, we all bring value, and we need to stick together to push this work forward because the time is now. I hand this over to Annette.
Hello. Okay, I'm going to tell you a little story, and this is totally off script. Deb doesn't know this is coming, but I did call her one morning, and we were talking about, role delineation and how we all just step forward and we do whatever we need to do. And so she shared with me what she did that morning. That morning, Deb was the janitor. No one showed up to clean the bathroom. The bathroom was a mess, and yes, she cleaned the bathroom. So there you go. Us nurses seem to always get it done. So I am the AAACN rah-rah girl, and I'm here to tell you, the people that have gone before us in NSIs, thank you, thank you, thank you. Anybody that's been on the NSI group before now, are on the group right now, people that have done the industry report, people that have worked with CalNet, could you guys please stand? Because you guys have done important work. Cindy, stand it up. There you go. Stand up. Thank you. Because there's a huge foundation that our group gets to build on. So AAACN recognized that our inpatient colleagues had all these awesome things like falls and CLABSI and CODI, and if you guys don't know those initials, it's bloodstream infections and urinary tract infections. So in 2015, they saw there was a need for ambulatory because that didn't really fit us. And of course, that's why we're here. We don't actually fit. So the board commissioned a task force to look at ambulatory NSIs, and two important goals were met through this group. And it was huge. One, the industry report of ambulatory NSIs was written. And that is online right now, and it's on the website, the AAACN website, under NSIs. And two, the AAACN then made that partnership with CalNUC. And it was an official partnership, contract signed, all of that good stuff. And actually they used that to develop and pilot test the measures that we use today. And it also made it into a structured, reportable database. They used technical experts, and it represented 150 organizations, and it was all of us. 150 different organizations weighed into this work, and that's why it was piloted, and that's why it developed. Now, that being said, there's been some evolution since then, and CalNUC, all of their data and all of that was purchased by Press Ganey. Press Ganey owns NDNQI, so you'll hear in presentations, those words kind of used together, separate, but it's kind of the same. So that is where the work went, but we're still going forward. Isn't that awesome? We are still going forward, and they are now re-looking at that industry report. How far have we come? Where are we? What is the evidence out there? Is there evidence